In this slide, I just want to touch a little bit upon the operating cost structure and how specific cost items contribute to the overall cost structure of the hospital. So professional costs of doctors would be in the region of about 28% of the overall cost structure. Staff and personnel costs, nursing, administrative, marketing, all of the rest would be around 20%. Material and pharma costs, which are very sensitive to patient demand, is about 30% of the overall costs. Admin and administrative cost, another 18%. Marketing contingencies, typically this can change, but I would imagine it would be about 1% of the overall cost. These costs are of two types. As I said before, we have costs that are variable and you have costs that are fixed, right? And variable costs, we know, do not change. These are costs that change with patient volume, and fixed costs are those that do not change with patient volume. You can further divide these costs into four types. So costs can be partitioned into direct and indirect components. So direct costs could be identified specifically and tracked to a specific patient care service. Indirect costs, conversely, are not directly related to individual patients, but are incurred to support the clinical services. So if you take these two aspects into account, you could arrange costs into four subcategories. And I mentioned this earlier: variable direct, variable indirect, fixed direct, and fixed indirect. Generally, in my experience, profitably run hospitals try to keep their variable costs at around 35% and the fixed costs at around 65%. That would be the ideal mix, but you can also see a 30-70 as is on the screen. And the other point to keep in mind here is that those departments that have the largest proportion of costs have also the highest potential for cost reduction, especially those components where there is a high level of variable direct costs. So, for example, reduction in operating room or patient ward costs is likely to yield the largest cost gains for, let's say, for surgical patients. And therefore, the biggest focus that hospital management should look at when they're looking at cost control is to look at variable direct costs. That is where the maximum potential exists. Trying to cut elsewhere might not give you the results. You might not see the actual implication on the bottom line. And sometimes it will just lead to conflict and, lack of alignment. So as we get towards the end of the costing and costing methodologies, I would now like to close this section with an aspect that is linked to the doctors. So there is this thing known as clinical variability, which has a significant impact on costs and costing. And this is due to doctors and their idiosyncrasies, nothing to do with the patient, nothing to do with the surgery or the medicine or the intervention. And because of this, there can be significant cost differences for really no good reason, only because of personal preferences of doctors. Let us look at clinical variability up next.